Thank you, Robin. Okay, our final speaker, and then we will have actually quite a bit of time for discussion, which is terrific. It's Dr. Brad Zebrack. We're going to be changing gears a little bit and looking at psychosocial issues.
Having a last name that begins with Z, I often hear the word final. It was advantageous in middle school when I could be in the back of gym class and not have to do my jumping jacks because the teacher couldn't see. But in settings like this, I'm often challenged to kind of perk up the audience, knowing you've been sitting for about an hour, a little over an hour, knowing you may be getting messages from your stomachs or your bladders. But if you can hold in for maybe another 20 minutes or so, we'll be able to get through this section on the psychological and relationship challenges for AYAs. I gave this presentation an alternative title as well, just to give you an idea, hopefully in this presentation, of what it's like to be an adolescent or young adult with cancer. I know later this afternoon we're really going to actually hear more from the words of survivors who have honored us today and are going to share their stories with us. But at least from the studies and the work that I've been involved in, just some of the comments that I've heard as a clinical social worker running support groups for young adults, and some of the research that I've done, I've heard things like young people saying everyone in the support group is at least 20 years old, overwhelmingly breast cancer patients. Other perceptions of things like hospital volunteers are primarily very nice people, grandma's age. Young people also say they have few opportunities to meet other young adults who are experiencing cancer. And they also talk about how some of the young people that they meet through their experience die and that they have to deal with that element as well. So an overview for the next 20 minutes or so, I want to talk a little bit about the psychological impact and what we know about the psychological impact of cancer for adolescents and young adults, what some of the relationship challenges that they have, a little bit about their psychosocial support needs, and then talk about what the implications of these findings could be for practice and policy. In terms of the psychological impact, a little bit of research and evidence that's out there does report on psychiatric symptoms. Some of the work I've done in a longitudinal study of data I'll present in a moment looks at depression, anxiety, and post-traumatic stress outcomes in this population. There's also reports of impact on cognition, the ability to think or concentrate, behavioral issues, emotional issues, challenges in terms of spirituality, challenges that interfere with young people's ability to cope with cancer. Earlier, Karen Fasciano talked a little bit about the developmental challenges. We're talking about young people who, the frontal lobe and the frontal cortex is not even fully developed yet. So the ability to cope with some of these incredibly life-altering instances is very difficult for young people who just haven't had the experience. Many of them, have not even experienced a grandparent who's died. Many have never been to a funeral. So these challenges to mortality come totally out of the blue to them. They have very limited experience in how to cope with some of these issues. I also want to touch a little bit upon potentials for positive adaptation, growth, and resilience, because I think it's important to think not only about the negative impacts because if we're going to develop interventions, we want to talk about not only preventing the bad stuff from happening, but also identifying ways that we can promote positive adaptation and enabling these young people to move forward in their lives after cancer. So from the AYA Hope study, I had an opportunity to analyze some of those open-ended responses. And one of the most often, one of the comments we saw most often, if you remember, there were about 524 responses. Half of the people in the AYA Hope study wrote something in those open-ended responses. And of those, 15 people wrote basically this: cancer sucks. That is the adolescent young adult expression of emotional impact. Captures it very well. Others were a little bit more articulate in saying things like, since being diagnosed, I have not slept well, I feel depressed, scared, constantly have a feeling of wanting to be home with my family. I was very social before, and now I don't do very much. So besides exemplifying some of these impacts of fear, depression, some of the other comments in terms of psychological impact, people talked about fears of recurrence, fear about how to manage the distress and the emotions, not only of their own emotions, but also how to manage the emotions of others, their parents, their friends, and how to respond to, feeling burdened by the emotional response that they would get back when they would tell other friends and family members that they had cancer. Share with you a little bit of study funded by Hope Lab, a private nonprofit foundation in Redwood City, California, we were able to conduct a longitudinal study looking at the prevalence and correlates of psychological distress and changes in distress over time for AYAs, and to also track psychosocial service use and needs over time and identify the extent to which preferences or needs for supportive care services were being met or not. So this was a longitudinal study design. The patient population ranged from 14 to 39 years old, and we did stratify, so we were able to do some analyses by these 3 developmental subgroupings within AYA. So we had teenagers between the ages of 14 and 17. We had the emerging young adult population of 18 to 25-year-olds, and then young adults 26 to 39 years old. Eligibility include all invasive cancers and the ability to write in English or Spanish. So data collection, we collected data for 2 years, and for each case, we collected data over a 2-year period with 4 data collection time points. We recruited folks to study within the first 4 months of their initial diagnosis. This was all clinic-based recruitment at 3 adult care facilities and 2 pediatric cancer centers across the United States. So we had initial diagnosis, then we had a 6-month follow-up, a 12-month follow-up, and a 24-month follow-up for data collection. This was serial recruitment. So over the 2-year period, we had a total of 286 eligible adolescents and young adults. We recruited 215 to study, so we had a 75% response rate. We used the brief symptom inventory as our measure of psychological distress. So the brief symptom inventory can do a few things. It gives us an overall psychological distress score, but it also calculates subscales for depressive symptoms, somatization, and anxiety symptoms. And what we were able to look at was that, and the other way you can score it is that there is a threshold cut point for clinically significant distress. So there's a certain point at which scores above a score of 63 basically indicate a need for some kind of referral for psychological follow-up. So at the time of diagnosis, that first baseline, we had 215 respondents. We had a prevalence of 28% of AYAs, indicating a score necessitating indicating clinically significant distress. That prevalence dropped at 6 months to 16%, and then it increased to a prevalence of 23% at 12 months. Now, this overall score of the GSI, the global score, this change from 6 months to 12 months was not clinically significant, was not statistically significant. However, when we looked at the subscales, when we looked at changes in anxiety symptoms, the change in anxiety from 6 months to 12 months was statistically significant. Overall, 35% of the AYAs indicated some kind of clinically significant distress at some point during the first 12 months of diagnosis, since diagnosis. One of the other things we want to do was to try to identify correlates, what might have been some of the predictors of distress. And we found this model that, that's been used in psychological response to trauma that we found was going to be helpful to us in understanding and perhaps classifying or clustering our AYAs into 4 categories. You can see that theoretically you could conceive of one group of young people or one group of people responding to trauma as being chronic, that at the moment of trauma impact, there's a high level of distress in response to that trauma, and that distress retains itself over time. So that could be identified as your chronic group. Second, you could have a group that is delayed in their expression of distress, that not really identified as clinically significant at the time of the exposure to trauma, but over time you see an increase to clinically significant levels of distress. So that's your delayed group. Third, you'd see a recovery group where you would have an immediate impact in terms of a clinically significant distress response, but then that distress response would resolve over time. And then finally, you'd have a 4th group, which Bonanno identifies as your resilient group, that while there is some impact or response to the trauma, that response never achieves a level of clinically significant distress. So we wanted to look at our data and to see if our data could replicate this theoretical structure. And what we found is that we were able to do so. In terms of the chronic responders, about 12% of this sample of, here we have 152, there's 152 AYAs who completed surveys at all 3 time points. So 12% of them retained or maintained this chronic level of distress throughout the first year. This is, even though we had 2-year data, I'm just showing you the 1-year data here. So over 1 year, 12% maintaining that chronic level of distress. Another 15% moved into that delayed response, so that by 12 months follow-up, they were still experiencing clinically significant levels of distress. 20% fell in that recovery area where they demonstrated clinically distress at baseline, but then resolved over time. And then about half of the sample maintained that resilience trajectory throughout. In terms of how people talked about psychological response, you saw the cancer sucks being the negative sort of representation. And yet people also talked about the positive impact. This again from the AYA Hope study, a young person writing. It was a devastating experience, but it changed my life. I became more positive, more health conscious. I exercised more. It allowed me to look at life differently. But every day I think about it and I seem very scared that it may return and I may not be strong enough to fight again. So we have resilience, we have negative impact, and sometimes in the same person we see both. Joan Hossey in her work from childhood cancer survivors talked about this in terms of being the two faces of the cancer experience, both the elements of desperation and fear, but also of celebration and hope. And we see that reflected in a lot of the comments, the open-ended comments. In terms of the relationship challenges, AYAs talk about impact in not only relationships with family, but friends, spouses, partners, their peers, raising questions about how do I talk about cancer with my friends. There's certainly a risk for isolation, young people talking about their friends dropping off the face of the earth, they stop calling, or maybe they were real supportive at the beginning, but when you're 19 years old, you're diagnosed with leukemia and you're going to be going through 2 to 3 years worth of treatment. After a while, a lot of your friends get tired of dropping by and calling, and when you just don't have the energy to invest in maintaining those relationships, that places a lot of these young people at risk for isolation. Issues specifically, developmentally specific, are around dating and disclosure. How do these young people talk about their cancer experience in the dating world when they meet somebody who may become a potential spouse or life partner? At what point did they talk about these issues of fertility risk? What about sexuality and intimacy? Developmentally, these are young people exploring aspects of sexuality, getting involved sexually, sometimes for the very first time in their lives, and yet cancer impacts them in ways where they don't feel physically attractive, they don't feel sexually attractive, and then the emotional impact is tied to that because they just feel bad in response to some of that, and then it gets played out in relationships and risks for isolation. Parents. Young people talk about their experience with their parents not only being, the parents being overprotective, but also in the other direction, young people talking about being protective of their parents, not wanting to tell them, not wanting to worry about them. You also think about young adults who perhaps not only moved out of the home, maybe they've moved to completely different cities, and oftentimes then go through the experience of cancer and cancer therapy on their own because they don't want to call mom and dad who are 3 time zones away and get them worried about it. But then it puts them at risk for things like how are they going to get to their cancer therapy? Do they have friends in the new geographic area where they're working in that they can rely on to help them out in whether it's getting to treatment, cooking meals, helping them with daily living, and so on. So a lot of these young people, they also feel social pressures. They feel different from their peers. And think back about when you were a teenager, what was the worst thing that could happen to you? Is that you look or feel different from everybody else, feeling that you're a misfit. And this is totally what happens to adolescents and young adults. They feel that they don't fit in. And at the same time, they just want to feel normal. And they're challenged with thinking about what does it mean to be normal? And as they go through therapy, even then thinking about how do I define normal? What is a redefinition of normal for me? Are some of the challenges that these young people go through. They also talk about drugs and alcohol very explicitly. It's all around them in their world. Going out to the social scene, being in bars, hanging out with friends, not working, Not working is a risk, being unemployed is a risk factor for increased use of alcohol and drugs. Well, when you're going through cancer treatment, you're not working, you're at a greater risk for exposure to alcohol and drug use. And these young people are challenged with how to manage these challenges, how to manage these struggles. Dating and disclosures, I mentioned a moment ago. How do you communicate and reveal this history? You're in a relationship, there's a possibility of engaging in a long-term commitment or marriage, and then you get diagnosed with cancer. And then all your dreams about a family, raising children, having children. How do I go to this partner and say, you know what, now I don't know if I'm going to be able to have children or not. I don't know if we're going to be able to achieve these dreams that we've had. These are the young, the fear of rejection that the young person with cancer may experience as a result of divulging and then having to move forward in that relationship. So a couple of comments that really highlight the challenges in terms of relationships. I lost a lot of people who were very close to me. I disappeared for a couple of months, and when I finally returned, everything was not the same. The people who knew my situation did not know how to approach me. I felt they had no idea who I was, and I wasn't too sure if they really cared. And this is not just about friends. This is even about family members, young people talking about family members who after a while just stopped asking about how they were. And it's a really tricky thing because the young people also say, I get so tired of everybody asking me about how I am. And then on the flip side, they're aware of when nobody cares, when nobody expresses any type of concern. Another comment, my spouse did not express any interest in learning about my cancer. He was and is unwilling to talk with me about my feelings or my fears. So when young people go to that commitment and they make that comment about till death, in sickness and in health, and death do us part, these young people don't think that it's going to hit them so early in their lives. That's the stuff that happens when you get old. But when it challenges them early on in the relationship, it's really not something that they're very well prepared to deal with. So I want to kind of summarize what we know in terms of the adolescent young adult population. At the top end of the pyramid, what we know is that within just the general population, there's a prevalence of psychological distress and major clinical depression of anywhere between 3 and 10%, which means just because you have cancer, just because an adolescent or young adult has cancer, doesn't mean that they have any other kind of pre-cancer mental health history. 3 to 10% of them are coming into the clinical oncology setting with some kind of precancerous mental health distress, psychological distress that is going to influence their care, it's going to influence their management. We have to take that into account in terms of clinical oncology care. In terms of the studies looking at psychological distress, going back to about 2001 with work by Zebrack et al., where he also did some stratification of distress by age, we see a pretty broad swath, a real range of studies looking at distress, anywhere from 6% to 41% prevalence. I think what's notable in most of these studies is that the level of distress does not vary by the type of cancer. I think this is an important point to make because when we look at the types of cancers within the adolescent young adult population, some of them are going to have 80 to 100% rates of survival, long-term survival, things like Hodgkin's disease, testicular cancer. Others are going to be more serious with perhaps less than a 50% chance for survival. And yet this chance for survival is not related in any way to the psychological distress. When we looked at our differences in our four distress trajectories, we did not see any difference in those 4 trajectories by age subgroups, by gender, or by cancer type. And then finally, the third area, the psychosocial support needs. When we looked at AYA's reports of needing and wanting information about cancer, 57% at 12-month follow-up were still indicating that they wanted or needed information, not just about their cancer, but long-term follow-up. They wanted information or needed information about exercise. They indicated wanting or needing information about diet and nutrition, fertility information, were the information, aspects of information we asked about. At 12 months, 41% reported unmet need for counseling, whether it was counseling from a mental health professional or counseling specific to sexuality and intimacy concerns. might have been about family counseling. Also included in that subject, in that domain, was peer support or camps or retreat programs that are specific for adolescents and young adults. So 41% of the sample were reporting that still at 12-month follow-up, their need for those counseling and supportive care services were unmet. And then finally, in terms of practical support, this was assistance with health insurance, transportation, child care. 39% of the sample were reporting that after 12 months of treatment, they were still not getting those needs for practical support met. So why is it important? What might be the explanation? Why are some of these young people not getting their needs met? Perhaps it's out of a fear or the stigma related to the use of mental health services. Perhaps it's that the AYAs don't want to be seen as different from their healthy peers and don't want to identify publicly or go out and seek these services. Perhaps it's by a lack of availability. These all may be explanations. But I want to point out a study in 2013 and looking at cancer patients in general, and the most often response given to why cancer patients don't get their needs met is due to the lack of knowledge or perceived unavailability of services, which in a study by Forsythe, and Erin Kent is in the room, she can answer more questions about this study. But this was an indication that this was a study, 2010 National Health Interview Survey of 1,177 survivors of adult onset cancer. So we know there are some young adults in there, but we don't know the proportion. But when you look at that whole sample, 90% of them saying the reason I'm not getting my psychosocial care needs met is because I don't know what's out there. I don't know what's available to me. Why is this important? Because we also have a body of knowledge that suggests there's independent studies, there's systematic reviews that emphasize that the psychologically distressing problems created or exacerbated by cancer can be effectively addressed by psychosocial and peer support interventions. And one of the key components of the Institute of Medicine's report, Cancer Care for the Whole Patient, back in 2007, 2008, really identified this area as really an inadequate aspect of cancer care across the country for cancer patients of all ages. In terms of the implications for practice and policy, so if we look at the psychological, psychosocial challenges being experienced by adolescents and young adults, in terms of their emotional functioning, some of the psychiatric symptomatology that they may be experiencing, the life disruptions, the relationship challenges, their coping deficiencies, it's important to pay attention to these things because they may have an influence on proximal outcomes. And I say may because we don't have the research yet that's really looked at the extent to which experiencing these psychosocial challenges are related to things like adherence to treatment or completion of therapy or satisfaction with care or the quality of care received. We don't know the extent to which these psychosocial challenges may be related to survival, quality of survival, also as well as institutional efficiencies. If we look at institutional outcomes, and we're talking about models, to what extent might new models of AYA care be contributing to improved outcomes? These are the questions that are on the table for us to pursue as we move forward. In terms of the psychological, psychosocial challenges, some of the recommendations that I take away from the work that I've done in this area and looking at the work of others, I think promoting peer relations is a critical piece for AYAs, very unique. Not so much unique to AYAs. I mean, there's studies showing that social support, peer support is critical for cancer patients of all ages. But when we consider the developmental stage and the challenges faced by adolescents and young adults in general, trying to engage socially, peer relations, promoting peer relations for cancer, AYAs with cancer is critically important. The comment about the utilization of social media, I think, has a really great potential for enhancing psychosocial support for AYAs. In the next session, you're going to hear more about survivorship care plans. And I think survivorship care plans that come from a patient-centered point of development may have great potential. Talking about engaging adolescents and young adults in the development of their own in their own survivorship care plans may have great potential. And as mentioned earlier, just the greater need for further research in this area to help identify who's going to benefit from what types of psychosocial support interventions, and also when throughout the trajectory of illness is also important. And with that, I'll just thank and acknowledge many of my colleagues who are here in the room and the work that we've been doing. And I think at this point, we're going to open it up for questions.